course, I'm very excited about the ADAURA trial. I worked on it with a steering committee of 3 PIs myself, Dr. Yilong Wu from China and Masahiro Suboi from Japan. It's just been amazing working with them and with all the colleagues around the world on this trial. Well, these data were presented at ASCO. ADAURA basically took patients with resectable lung cancer, stage 1 to 3A, and then gave them adjuvant therapy with chemotherapy as indicated, and then randomized them to osimertinib or placebo. I'll be honest, I would never have expected to have spent so much time on this trial the last 6 months. It wasn't set to report for another 2 years. The trial would have been positive with a hazard ratio of 0.7, a 30% benefit. But of course, at ASCO, I showed on behalf of the team that in the patients with stage 2 and 3A disease, after resection, the hazard ratio was 0.17, an 83% improvement. And actually, the updated data here at ESMO for the stage 1, 2, and 3. So even when you add back the stage 1 patients, who many of them are probably cured without anything, we have a hazard ratio of 0.2, 80% benefit. So tolerability is quite good. The forest plot is positive across the board, especially important to point out that patients who had or did not have chemotherapy, no difference. So a very positive trial, but it's disease-free survival. We don't have overall survival yet. How can we? The trial was unblinded early because of these compelling results, and it is being followed for survival. I made that point at the meeting that we continue to keep the patients and the doctors blinded, and we're following patients. We've added a mandatory crossover in the trial, so patients on the control arm on progression will get osimertinib. That said, can we glean more facts and information as we wait for the survival? And the answer is yes. We can look at the sites of metastatic disease. And as we would expect, about 11% of patients have progressed on the osimertinib arm and 30-40% on the placebo. And if you look at the distribution, there are many more patients with metastatic disease on the placebo arm than the osimertinib arm. And it makes sense because the osimertinib is preventing metastatic spread. And if you look at the sites of recurrence, it's as you would expect, lung, bone, and brain. So we looked at the brain metastases, especially here at ASCO. We mentioned it, but here we actually showed the data. And what was seen is that there was a 10-to-1 increase in brain metastases in those patients who were on the placebo versus the osimertinib. The hazard ratio for brain met recurrence was at 0.18, meaning there was an 82% decrease in patients with brain mets if they were on the osimertinib. In my opinion, that's quite compelling. The morbidity of brain metastases is quite high, and to prevent that is an important aspect of this trial. And now we have these data as we await the survival numbers. Later on this year or early next, we'll present quality of life, some of the data on who received what therapy after the trial. But in my opinion, these are practice-changing data. I'm certainly hopeful that soon we'll have the ability, with appropriate approvals, to use this drug in patients around the world, who have EGFR mutations. And you know what? It's going to mean that we're going to have to start screening for mutations at the time of surgery. And I don't think it's just going to be EGFR mutations. I think we have a new paradigm here. And many of the new targeted therapies, there are 7 or 8 of them now in lung cancer, we should think about adjuvant trials, and that's already being done. So we've taken targeted therapy, 20 plus years in development. We've targeted it to EGFR mutations, and now we've brought it to earlier disease where the tumors are less heterogeneous, more driven by EGFR mutation, and hopefully here we'll have an even better result. So very exciting. I'm excited to be part of this, and it was a great ESMO to see those data presented. I should also mention that simultaneously it was published in the New England Journal of Medicine, so the full data set are now available, and there's a great deal of supplemental data too online if one wants to look at it there as well.